Hello and welcome to Single Payer Radio. I'm Paul Hoppy, broadcasting from the Hayburn Building in Louisville on the WFMP 106.5 Forward Radio Community Network. Informative and entertaining programs are available 24 hours a day, 7 days a week. Our Single Payer Radio program airs every Monday at 2 p.m., Tuesday at 7 a.m., and Wednesday at 11 a.m. And we also stream our show on SoundCloud. The show was a project of Kentuckians for Single Payer Healthcare in conjunction with Physicians for a National Health Program through its Kentucky chapter. We produced this program because we believe healthcare is a human right. We advocate for a national, not-for-profit, publicly funded, single-payer healthcare system that works for everyone. The views and opinions expressed on our show are those of the speakers and not the station. Our station relies on volunteers like me and your ideas and donations to keep us on the air. Today, Drs. Mike Flynn and Gene Shively join me as co-hosts, and our focus is on free health clinics in our community. So let's jump right in. Dr. Flynn?
Yeah, this is Michael Flynn, retired surgical oncologist from the University of Louisville. Let me begin with the usual disclaimer that any comments I make are my personal views and do not represent the views of the Department of Surgery or the University of Louisville. Gene?
This is Eugene Shively. I'm a retired general surgeon from Campbellsville, Kentucky. I've spent my whole career in rural Kentucky. What I say does not represent the Department of Surgery at University of Louisville or the University of Louisville, nor does it represent Taylor Regional Hospital in Campbellsville, Kentucky.
So our topic today for this program is the Family Community Clinic. As Paul indicated, this is a facility that provides health care to the uninsured, staffed by volunteers. We have three special guests to discuss the clinic details to us and our listeners. I plan to briefly introduce each guest, ask each guest to provide the personal information and their involvement with the clinic when they have an opportunity to make some comments. So these are three retired physicians from different backgrounds. Steve Lipman, a retired psychiatrist, Deepak Azid, a retired internist, and Manuel Grimaldi, a retired medical oncologist. Gentlemen, welcome. Thank you for coming on to do the program and talk about this important facility. We're going to give you each an opportunity to make comments for as long as you'd like. While you're making the comments, I would ask each of you to discuss your activity in the clinic, as well as providing whatever background information that I haven't provided in your introduction. So we're going to start with Dr. Lipman, then have Dr. Azid, and finally with Dr. Grimaldi. So, Steve, the floor is yours.
Good morning. Thank you for having us. Greetings to everybody. Anyway, we're going to talk today about Louisville's Family Community Clinic. It's a free medical clinic at 1420 East Washington Street, and we offer care to people at no cost. I'm Stephen Lipman. I'm a retired physician, and I'm joined by Manuel Grimaldi and Deepak Azid. We are all volunteers at this clinic. We serve people without health insurance. We do not offer care to anyone with any kind of insurance, even Medicare or Medicaid. And remember, when we say free medical care, that just means there's no such thing as free care. It's just other people are donating the money and or the volunteer service time. And that's what the three of us do. We're all volunteering our service time. Some of us also volunteer a little money. I'm a psychiatrist. I primarily do primary care at this time, but I also do a little psychiatry. Let's go ahead and talk about the clinic. Family Community Clinic initially started in 2011 because of the medical service deficiencies in our community. And to fill some of these gaps, the clinic was begun by the George and Fisher family, together with Father David Sanchez and parishioners from the St. Joseph's Catholic Church, and they opened up in a little small under the church basement to provide local health care to those people that have unmet needs. And shortly after that time, I had begun hearing about them as the clinic began to gain some notoriety in the community, and that's how I heard about the clinic and why I joined. FCC, as we call it, Family Community Clinic, is a non-profit 501c3 organization run essentially by 7 paid staff and about 300 volunteers or more, plus or minus at different times, providing primary medical and dental care to uninsured folks who have unmet health care needs. It varies over time, but we have about 25 physicians and about 27 dentists who work varying amounts of time at no pay. We also have about 40 nursing staff, all volunteers also, some RNs, some APRNs. And we having a lot of non-English speaking people. We have about 30 interpreters and a bunch of other helpers like social workers, counselors, clerical folks, administrators, and most of all of them work, again, without pay. But on the other hand, the clinic provides all the clinicians with malpractice insurance, unfortunately necessary these days. Most of the volunteers come through word of mouth, like me. I just heard about it through another service and decided to add my time to it. We're also available resources you can join by looking online for us. But anyway, we're mostly word of mouth and some staff outreach through various partnerships. We have a lot of connections with University Hospital, with universities in town, and other affiliations. So after starting in about 7 years in a somewhat cramped circumstances, 7 years later, 2018, the clinic got remodeled into a very modern, purpose-built medical and dental clinic, and that opened next to the church in area provided by the church. We have a reception desk, we have 2 waiting areas, tons of exam rooms, some offices. Most of the medical equipment was donated. And then 1 year later, we added a dental service together with the Free Smiles Clinic dentists, and Delta Dental gifted us with dental equipment. Now, what about the money? We received no U.S. or Kentucky funding. The finances are supported through tax-deductible donations from public facilities, from private organizations, from foundations, or just individual contribute. My wife and I have a little program to do that as well. Louisville Community Foundation gave us an endowment. Most anybody who can't afford medical care can come to our clinic so long as they don't have big financial resources, and they can get cost-free care. Now this cost-free thing includes laboratory tests, imaging like x-rays, mammograms, scans, ultrasounds, all that stuff we can provide at no patient cost through nearby facilities that we have connections with. We have also got a supply of medicines, of the common medications that are, and we can dispense these directly to patients to avoid patient cost for their pharmaceuticals. Now, on the other hand, a lot of patients, once they're on a medicine for a long time, if they're working and they can afford it, then we write a prescription and they can get their prescriptions through local pharmacies, and that allows us to have a little more money for the completely indigent, and then we can dispense those directly. Now, and of course, some of the medicines are sometimes not available. Certain ones they have to buy by prescription, but this allows us to have more services for the truly indigent person. Now, to be a patient, should be over 2 years of age, and all of our appointments are pre-arranged by telephone. And that number is in this area code, and it's 284-8444. So 502-384-8444. Anyway, and the clinic is open most daytime hours, 5 days a week, but not on the weekends or holidays. And one of our big, proud components is that we can provide this care in a non-rushed environment and not having to be worrying about money all the time. In 2024, just to give you some ideas about the volume, we did 3,400 office visits, all prearranged by appointments. Walk-ins are not necessarily welcomed, but we've taken walk-ins before. Or if somebody gets hurt on the street, they can come walk into our clinic too. But and besides the primary care, blood pressure, diabetes, that sort of stuff, besides the primary care, we offer a little bit of subspecialty coverage in dermatology, endocrinology, neurosurgery, oncology, and psychiatry. I'm one of the ones that does a little psychiatry, and we got Gary Weinstein also, and previously other psychiatrists. Now, on the other hand, when you have a medical emergency or a very complex, difficult to treat illness, or a hospital necessary case, or somebody that needs very specific subspecialty attention, we arrange that, and we do that. We'll make the arrangements to help have somebody go to other facilities, mostly the university hospital emergency room, the emergency department, or some of the university hospital clinics, also the family health care centers, and occasionally some of the private hospitals or other clinics. And one other part of it is the gynecological, reproductive, pregnancy, or obstetrical care is usually obtained through referral by us at the family health care clinics. So, that I would like to open up to the other fellows to talk about.
All right, thank you, Steve. Deepak, your turn.
I think Dr. Lippman gave a wonderful overview of our clinic, and I would like to especially special thank to Dr. Grimaldi, and that's the one who motivated me to come to the clinic, and I'm enjoying every day. Being an internist, I see all chronic conditions and some of the acute conditions also in the clinic. My bread and butter is, hypertension, diabetes, and so on. So we do provide, as Dr. Lippman mentioned, we have medicines available for diabetes, for hypertension also we provide, and we manage patient very well because we can see the patient not one monthly basis. If we start a new medication, we want to reevaluate the patient. We can see the patient in 1 week or within 2 weeks, and we try to give the very personalized care at this clinic. And I'm so glad that we have this clinic that more of our community members can take advantage and take care of their health so that they don't have to get sick because they don't have insurance. And that is my few statements. Thank you.
Well, thank you, Deepak. Manuel, your turn.
Dr. Grimaldi is the one that got me started too. He was a dynamite guy.
Thank you very much, Steve. Little to add to what Deepak and Steve have said about the clinic. I'm gonna dwell on something a little different. When the clinic was founded, was because a solidarity effort by the community at St. Joseph Catholic Parish. I think they were about to close it, and they sent, I may be wrong on that, but they sent David Sanchez, Cuban-born padre or priest, and that there was an empty parish, and then all the Latinos began to flock to worship there because of the language and other features. And there was an old German population there. There was this hero of mine named George E. Fisher and his wife Ellen. And they became conscious of the need of this population. They had no money to go to doctors and no way to get health care. And so with the help of some other members of that parish, they facilitated the renewal or renovation of a basement at the rectory. And in 2011, we started working there. I was fortunate to be called by Father Sanchez in a party and say, "Are you retired?" I say, "Yes," and come to work. You know, as a Catholic boy, you don't say no to a priest. And it was wonderful because I just retired from a busy practice for 30 years as an oncologist. Very satisfied with my work, but it needed to look at new frontiers. And I felt a call to become part of it and believe in it. And of course, you know, we suffer with our patients because their socioeconomic situation are, to say the least, tragic. And the impetus of George Fisher, whose lemma was to be sure that they get the best care. And I would add for the money, because of course finances are always a challenge when it comes to provide care, specialty care, imaging, etc. But the spirit of the clinic is alive and well. I know that the volunteers that come in get hooked to it because they get to talk to the patients. I mean, that's more therapeutic than 20 CAT scans and expensive medication. So we have developed the art of communication. And we do surveys of satisfaction surveys of our patients, and a majority of people are very satisfied. But the main thing, and that's a selfish aspect of what we do these days, we are happy to be doing that. We're in a rush. We give them all the time they need. And even when you cannot help in a special situation, you need to find a different place for the person to seek medical care. They thank you. They thank you. And we never feel defensive about what we do there. We explain things to the patient the best way we know to, and generally it saves us a lot of trouble. I'm challenged by the fact that, you know, we, coming from private practice, you're very concerned with malpractice. Well, I don't know of any instance where we have seen a situation that threatened that possibility. So there is a bond of trust. And as Dr. Lima would say, you talk to the patient right, the patient loves you. I will never try to take advantage of you. And there's a simple way to practice medicine in a way that is affordable. For one thing, you don't need to be doing all kinds of tests to figure out what to do. Sometimes you talk to the patient. Well, there was a professor of mine in Seville, Spain, who said, you talk to the patient, you examine the patient, and if you don't know what's wrong, then you order some tests. And you still don't know. You talk to the patient, examine the patient, and then if you still don't know, send it to Dr. Lehman or someone who knows more than you. And that's the spirit of the clinic. So I think the same spirit that led the St. Joseph community and the Fishers to create the clinic is the same spirit today in all the providers. And I must say there's another dimension, social dimension. We are engaged in educating the new doctors in an area of compassion. They come as a undergraduate student to do different services. For the most part, they're the scribes because some of us don't like to type. But they're there and they are witnessing how medicine is done. And I have wonderful cases of students that finish their medical school. And so this is one very interesting part of what we do because, Steve has been a professor all his life. So what sharing knowledge is good. I am a failed professor and I do like to share what we know. So I think the ethos of the practice still is faithful to the original calling that was to serve people. And we're learning every day. I'm making a lot of mistakes. That's why, we have committees in the clinic to allow us to keep guidelines and doing things the proper way. And it's wonderful to be a member of that. I've been there since 2011, I think, and they will have to carry me out in a pine box out of that place. Thank you for the opportunity to speak.
Well, again, gentlemen.
Manuel, you said a couple of things that resonated with me. That first clinic that we had down in the basement of the rectory, well, my daughter came to see it one time. She said, "Oh, this looks like one of those hippie clinics, just living on a shoestring." But we did the service. And we took care of people. It was wonderful. Then she came a few years later in 1918 or 20 or something. She came to see the clinic. I thought, oh my gosh, now you've got a real modern, up-to-date, cutting-edge clinic. So we've done both sides. The other thing you said that interested me is you and I, Deepak and I, and the other docs, we're always exchanging information, or would you see my patient, or what would you do about this? I mean, just the other day, I talked to Dr. Middleton, and I asked her some questions about hematuria, and she gave me a whole chapter. She Xeroxed off a chapter about hematuria, and she said, read it this weekend. So we're always exchanging each other's, and she helps me, and I help her, and you and Deepak and I exchange patients all the time, and that is another cross-fertilization. And I always bring students or residents to the clinic with me virtually every single time I've been in the clinic.
Well, gentlemen, again, thank you all for your comments and thank you for your volunteer work. Now, Gene is going to begin the conversation, and what I would suggest is whatever questions we ask, if you all want to comment, that's fine, or if just one or two of you wants to comment, I'm just going to leave that up to you. So everybody doesn't have to comment about everything, or you certainly can. So, Gene, you want to start us off here?
Yes, I would really like to thank you for the work you're doing. I would like to really ask you a personal question. We have a lot of talk about burnout among physicians, being unsatisfied with medical care. I would like to ask you, one, why are you doing this when you could be retired and doing something else? And the other reason is, has this really brought back your soul into why you really went into medicine? And do you think doing something like this could help people get over their burnout and really motivate people to really why they really went into medicine in the first part?
So I guess each of you is going to have to make a comment on this one. So Steve, why don't you start?
Okay, I'd be happy to do. I think burnout is one of the big problems with burnout is that there's too much money involved. The patients can't be seen. You know, I remember. I mean, I could talk about this maybe too much, but I remember when my dad was in private practice in the 40s and 50s and 60s. Every doctor in Austin, Texas, did so many days, whatever it was, of free medical care to go to the university, to the downtown hospital and take care of people. I remember going in those days of segregation. I remember my dad going to the black hospital. I used to make rounds with him sometimes. I mean, so one of the reasons we have burnout is that there's too much emphasis on money and people are pressured. I know doctors that work here in town and you have 15-minute appointments. By the time you get somebody in and help them up onto this table and take off their coat, you've used up half your time. And then the computer, I think, is another aspect of eating up time that doesn't help people and that alienates people. That one of the biggest problems in American society, as well as medicine, is lack of direct contact and rush. And the doctors these days are rushed. I think that's a big part of the burnout. Now, as far as for me, why I came here, it's pretty simple in some ways. First of all, we have this discrepancy of care. This afforded me the opportunity to do it. I like this kind of work. I've been doing somewhat disadvantaged care all my life. And the reason I came to Louisville in the first place in the 70s was I got a job at the University of Louisville to work in Louisville General Hospital that had some of the same philosophy, that we are here to serve the patient, not to make money for some stockholder. So the lack of the money influence is a big part of it. And to me, I mean, I'm energized by this. I love the fact that I can do patient care. And for me personally, as far as burnout, I mean, doing patient care is more fun than most anything else I can think of. And then there's another personal element. Our clinic happens to take care of a lot of refugees and immigrants. Well, I happen to be a birthright U.S. citizen, the son of refugee immigrants. So I can sort of give back. And that this allows me to do that, and FCC allows me to do that. And so that is part of the other reason for me personally. But even without the immigrants, I like the nature of this service, that we can give individualized attention without time constraints and without the influence of so much money influence.
Okay, who's next?
Okay, this is Deepak Azad. So, physician burnout from data what I have gathered is directly related to two main causes. One is loss of autonomy, and second one is electronic medical records. So, at Family Community Clinic, we have such a congenial environment. So we have our autonomy, how we want to see, how much time we want to spend with the patient, and there is no money involved. So that was another good thing. And we do have EMR, but luckily we have Scribe also available. And I am learning this, our Family Community Clinic EMR, which I'm learning slowly and steadily to be more productive and more patient oriented way I do. So if I'm with a patient, I do not try to shy. I try to do it later on, so patient feel like I'm giving them 100% of my time. And my motivation to come to this wonderful clinic is I'm also immigrant. When I came to United States, I had $200. Luckily, I was young and healthy. But now I can see those who are coming from the third world countries like where I am from, people health can deteriorate at any time. And that's the reason when Dr. Dramali gave me opportunity, I said, I need to give back to the community. And we both have the same philosophy. We interact on a daily basis, including one in between patient, we meet each other and try to exchange the ideas. So camaraderie is so amazing. And I love it. I love it and love it to be at this family community clinic for the best interest of the patient. And I can meet my colleagues and take care of our patient as a one happy place, so that patient don't feel like that they are at a strange different place and they have to worry about from office visit to medicine, everything taken care of under one roof. So this is a great clinic. I hope more of our community members can take advantage if they have no insurance. Thank you so much.
Okay, Manuel?
You know, I consider medicine a calling. And then it turns out to become the best hobby you could possibly have. So burnout can be motivated or incited by the reasons that we have said, the interactions with the work, the demands of the work, the computerization. I don't want to see a doctor that is looking at a screen when he's trying to tell me something. I like eye-to-eye contact, and that's the beauty of traditional medicine. If you summarily read the Hippocratic Oath, the element of first do no harm is the great commandment. And do you think we do not offend people by not talking to them face to face and being interested? So I can conceive, perhaps it's selfishness, because my ego tells me that I have to be there in first line. But that's the reason, the reason for why many retirees are seeking the opportunity to be doctors. And as far as I know, my last years in private practice were very productive. I loved my patient. I was not burned by not liking what I was doing, but I knew there must be something better out there. And, when Father Sanchez told me, come to work to the clinic, oh, it's wonderful, thank you. And in my recruiting efforts to bring people to the clinic or talk about to people, I'm going to give you a business that you cannot refuse. When I tell you this, you will thank me because I'm doing this for you. And somehow this is an interesting way of selling a product. I could sell snow machines in Cuba, but I'd rather bring people to the clinic.
Okay, let me ask you a question about the financial basis or the foundation of how this works. First of all, for our listeners, if one of you could explain a 501c3, exactly what that is and how it works. And then it's my understanding that basically, aside from that situation, the resources that are come in from contributions and donations. Now, is that correct, or do you have another revenue stream that you haven't talked about? So I guess, Steve, whoever wants to talk about that, I think we and our listeners would like to have an idea of how this works from a financial standpoint.
Well, if you want me to, Manuel, you want to start or you want me to?
You do.
Okay, well, obviously we are a non-profit free medical service. We get no federal money. We get no state money. We're all donations or from foundations, from people, from organizations, hospitals, insurance companies. I mean, a lot of different organizations and entities or people give us money, and that money is translated into free care. And as a 501c, that means that is a entity that is created by the federal government in this country for nonprofit services in a variety of, public service organizations that do charity work of one kind or another. And obviously we don't make money off of this. We don't have stakeholders or what do you call them? Stockholders. We don't have to make stockholders happy. And the most important part is what the other fellows have talked about. Oh my goodness, is my wife not answering the phone here? The other thing that's part of that is what Dr. Grimaldi said about time with the patients. I think if your doctor-patient relationship is not optimal, then whatever smart things you do or recommendations you make are just not as likely to work or as likely to be adhered to, and even the placebo benefit. If you tell somebody you're looking right at them and grab their arm and say, I think this is going to help, that is already a massive step forward. And if you look at American medicine as practiced now, I mean, the doctors are standing up, they're ready to go, they're looking at their watch. They have assistants doing a lot of the stuff. And we have a lot more of the hands-on doctor-patient relationship. And that reminds me of something that Grimaldi said earlier. I remember my dad used to say, when he was a doc back in the day, well, after I talk to the patient, I just go into the exam room to see if I was right, even before the laboratory. But I mean, we're now more laboratory oriented than we were. I mean, even in my lifetime as an ER doctor, I didn't have a CAT scan or an MRI or an ultrasound. I mean, we didn't even have that stuff.
So
anyway, go ahead, somebody else.
A 501c3, if they make a contribution or a donation, is that tax deductible?
Yes, it is tax deductible in every case.
Yes, important information. Gene, you want
to? If we were able in this country to go to some type of healthcare system where everybody is covered, and do you think that would make a great big difference in healthcare and how we do things? If we could particularly get the for-profit system gone away and essentially a healthcare system that covers everyone.
Well, okay. Yeah, absolutely. I think we got rid of the insurance companies. We brought the pharmaceutical costs into line with other countries. I mean, I was looking at some drug the other day. It costs thousands of dollars in this country that you can get in Canada for $170 or something, and you can get in Germany and other countries in Europe for, I don't know, 120 or something like that. I mean, we are killing ourselves. We're killing our whole country by the amount of money we're wasting with prior authorizations and with insurance companies and with regulations and rules that kill the business. If we had universal health care, I mean, like if we said, okay, everybody's on Medicare or something like that, would be on a federal program, would be, I think, very helpful.
Well, our program is promoting Medicare for all. That's why we've been doing this for the last 3 or 4 years.
Medicare for all, and I don't know if we'd even call it Medicare. I remember that when Kentucky decided to join Obamacare, they said, "I don't want Obamacare, but I like the I don't want Obamacare, but I want the Affordable Care Act insurance." So,
Yeah.
you
Okay,
know, I don't care what the name is, but to have universal health insurance and the ability of our pharmaceutical companies to pay what other countries pay.
Let me ask you a question about the medical liability insurance. It's my understanding from what you've said that's provided by the clinic. So I'm assuming that only applies to your activities at the clinic, and if you decided to go do something somewhere else, you would need to have separate medical liability insurance. Is that a fair statement?
Yes, that would be absolutely true. Now, most conventional policy, most conventional understanding in this country, if I was to go help at the scene of an accident on the way home, that would probably be Good Samaritan coverage. But I couldn't go to work for Norton's or Jewish or something as a private doc and be covered. They just cover our job, but Good Samaritan would cover you if you're on an air. I've helped out on airplanes several times. My daughter's done pulmonary care and delivered a baby on an airplane. I mean, those things, your insurance may not actually cover you, but you'd be sort of, I don't know how that works, but I don't think I have any anxiety about stopping at the site of an accident if somebody's laying on the floor.
All right, thank you, Gene.
Can you tell us a little bit if a healthcare professional, like a nurse or a doctor, who would like to join your group and help out, how they could do that?
Well, Grimaldi helped get me in the deal. I heard about the clinic and I came over there and he says, "Come on over here, boy, we need you." But anyway, he gave me a lot of confidence to do it too, especially that I hadn't been primarily a primary care doctor for a long time. But yeah, you can Google us, or you can use whatever resources you want to look up the Family Community Clinic. We also have a site that I mentioned earlier. The telephone number is 384-8444. You could come through that a little bit, or you can go to FAMCOM Clinic, FAMCOMCLINC.org, or you can just look it up online and find our websites, and there's a volunteer click that you can do, and then fill out the little application, and then you're welcome to join.
All right, I'd like to ask each of you to comment on your referral experience. Now, you mentioned University Hospital. Norton's and Baptist are both not-for-profit hospital systems. They get a tax deduction for providing care for the uninsured. So I'd like to kind of get a sense of your experience, one referring to U of L Health, and then how much referrals, or whether you refer to Norton's or Baptist as well. And again, I'd like each of you to make a comment about that, please.
Well, how about if Deepak or Manuel starts?
Okay. I want to make a small comment about the funding. We actually get a refund from Kentucky for the insurance. That's the only help we get financially from the government. I think it's $6,000-7,000 for the policy. Regarding referral, you have to play the art of negotiation, because some people don't have any money and they don't want to show up in the emergency room or go to a consultation because they walk out of that place with a bill. $500,000. So what we try to do is work with the other end, social workers, and try to discuss a pay plan that may be acceptable to the patient. And sometimes when we see a catastrophic problem, like I saw a young man with testicular cancer, that happened to me because I'm an oncologist. So I got a little blood work, very limited, and confirmed the diagnosis. And I called one of my buddies at the university. Knowing people is very important to get things done. And the kid was admitted, had his surgery, had a couple of cycles of chemotherapy, and still now is in remission. He's alive and well. But everything was taken out of emergency insurance. I don't know if it was Medicaid or something like that. But the problem is taken care of. So I think we have a great deal of satisfaction in getting those patients taken care of. It takes a little work, and they may be still in time, may end up with a little debt. I tell them, don't worry. If you don't pay, you go to jail, and they feed you there for free. And they laugh, and they go ahead and do it. I think our connection, especially for senior doctors that have been around forever, that you find people that will listen to you and take care of patients. So I don't know of anybody in my 11 years that was denied necessary medical care.
Oh, Deepak?
I concur with Dr. Grimaldi, what he mentioned. And I think we are very fortunate that University of Louisville is right in downtown, and access to some of the specialists is very crucial. And it's a win-win situation, but still sometimes it's very hard for some of the patients to afford the care, because if I don't know everybody or the whole faculty has changed, so that's where trouble has now begun, and everybody has to get permission of somebody to give the free care. So I do see some trouble ahead at how we are going to take care of complicated cases or patient who needs to go to the emergency room with their medical condition or surgical condition. So there is a need for better access to the health care. And as you mentioned, I also agree that it should be available to each and every person. And which way is a good solution, only the future will tell. But looks like the way in which our healthcare system is slowly changing is going to be the universal health care will happen sooner or later. It will not happen overnight, but I can see that how it transforming slowly, and looks like a single player system we are working on. And I wish you good luck with that efforts. Thank you.
Steve, you have anything to add to that?
Oh yeah, I could talk all day. Yeah, I think so. I remember a couple of years ago.
We don't have all day, but we have to listen to a few comments.
Anyway, a couple of years ago, I needed some renal consultation with a lady with nephrosis, and I got very good service. I even remember specifically that the attendings called me back and said, "Here's what I did," and sent a note and everything. Then just this year, I had a lady with 2 different stones removed by the University Hospital, renal stones. So, I mean, I've had good connections with the renal service. I remember right before the holidays, right before Christmas, we had a psychotic guy in our clinic that I thought had a drug-induced psychosis. I called the university hospital. I think what Manuel said, Dr. Grigaldi said, the personal attention makes it work better. I mean, I called the attending called me back in Reno. The same thing with the psychiatric patient. Sent him to the emergency room with a very overt psychosis, very profound degree of dysfunction. And the residents called me back, and we had contact the next day. The patient got better. I'm still seeing the patient afterwards. He's better. Some time ago, I talked to Dr. Bumpus, the dean, and Dr. Potts in ENT, and smoothed some relations for some ENT patients. I've had several people with pterygium, an eye condition. I talked to Dr. Soltow in ophthalmology and facilitated some contacts. Then I remember another case recently, maybe it's been 6 or 8 months ago, but I had a guy with some kind of a compression neuropathy. I sent him the next day. Our Dr. Banerjee, a neurosurgeon, saw the patient. Well, he sent the patient immediately to the hospital and saw him the next day at the university, where he still works part-time as a volunteer. So, and then the neurosurgery procedure was done, and so we had good connections. Now, and most of our gynecological type stuff and obstetrical is done through the Family Healthcare Center, but they also see some of the other people. We occasionally send people for non-female type issues to the family health care centers, and I've not had much. I've had no trouble with that either. Less personal because it is kind of an established connection. I just tell the nurses, this guy needs to go over there for blah blah, and then it just happens. But I haven't had much trouble with referral. Of course, it always takes a little more work.
Well, part of the question had to do with what your experience was dealing with Baptist Health and Norton's Health. Now, these are both for-profit health insurance companies that get a tax deduction for providing care for the uninsured or the indigent. And so I guess my question is there a process where you can refer someone to either of those healthcare systems? And if it is, how does that work?
Well, the only thing I can say that offhand is that Norton's does provide us with some mammograms. So we often get mammogram services through Norton's.
Let me ask one other question. It looks like that Medicaid is going to be drastically cut back. And how is that going to affect your clinic? And how's that going to affect medical care in Louisville and Kentucky?
Well, I'm sure I'm hopeful that the senators are going to stand up for not doing anything to Medicaid. But if they don't, our clinic will probably get more people. It might be balanced out by all the refugees they're sending home. I don't know what the numbers are going to be, but we are prepared if there's an influx of extra patients to try to add new shifts and new docs and new times. So I mean, we're already thinking about that. And
actually, we adding hours on Saturdays. Okay, that's in the making.
Yeah.
We're preparing for that proactively.
Well, before Corona, we did have Saturday clinics too. A lot of things. We used to actually even have more specialty services before Corona, and some of that deteriorated during the time off, so to speak. But yeah, I think we're prepared to do that again. Dr. Grimaldi just said we might have Saturdays. And we used to have Saturdays.
One other thing is that a blessing in disguise was the epidemic, is that we quickly responded to meet the needs of our patient by using telehealth. So it is an opportunity to maintain a follow-up of people that can be seen on the internet, and and provide care. So there's always a solution to problems if we search them and try to adapt to it.
I want to give you a 3-minute warning. So what
Wait,
I
just a
would like
second.
to
I want to
do-
say one more thing. The telehealth, yeah, there was a time during Corona where I was doing 3 shifts a week doing tele. I know that telehealth is not as good as the eyeball to eyeball personal contact. But one other thing, Dr. Grimaldi mentioned that through the internet, but a lot of our patients don't have a computer or don't have access to one or don't have good internet service. So I'm not doing very much telehealth now, but that I do is a lot of times just on the phone, because nearly every person can at least access a phone for a doctor's appointment.
We're down to the end of the lollipop, so I'd like to give you each an opportunity to make a very quick final comment, and then we're going to have to close the program because we're about out of time. Why don't you start, Steve, and then Manuel, but say it quick and because we're about out of time.
I love the opportunity to help people that need care and don't have the money.
Okay, that's wonderful.
All right, Manuel.
Well, for all of us, it's an honor to be of service altruistically, and we thank you for having us in your program and allow us to inform people that there's a good place in town, and we're willing to stay for a long time.
Well, listen, thank you for your service and thank you for coming on, and Paul's going to take us out.
Yeah, I'd like to extend the personal thanks to you guys for coming on. I was very touched by the work you do, and I'm so concerned about these potential Medicaid cuts. In the state of Kentucky, 5 out of 9 children depend on Medicaid for their health insurance, as well as 30% of adults. So I'm so grateful that there are folks like you that help out so much in the community. And for our listeners, I want to thank you guys for tuning in, and I'd like for you to please come back anytime and listen to Single Payer Radio. Thank you, and have a wonderful rest of your day.